folks on it are experts in prevention and evidence synthesis, and led by a chair and vice chair, serve 4-year terms, appointed by the director of the Agency for Healthcare Research and Quality, and we have a number of people who really have very deep expertise in analysis of evidence. So we make recommendations, and this is going to be very important, I think, for clinical preventive services targeted to primary care physicians. So it's not Eveline and it's not David Marin. If people are in your clinic, good chance they're not really the target for our recommendations. Our scope includes screening tests, counseling, and preventive medication. So that'd be aspirin and statin, medications for breast cancer, etc. Our recommendations apply to adults and children with no signs or symptoms. So we've heard a lot about the issues and challenges with people who are asymptomatic. It's true of all of our guidelines. And as you can imagine, when our recommendations may affect every adult, and these are people who are healthy, and so our bar for recommending something is pretty high because we don't want to do any harm. And so I think it's appropriate that it's high, but we can discuss whether that in respect to coronary calcium. So we review existing evidence. We do not do our own research. So we rely on people like Matt and others who are doing the work in the field to come to our conclusions. We evaluate the benefits and the harms of every service that we look at. Almost all preventive services do have harms. And we look at those very carefully. Just a quick word about our process. We create a research plan. The evidence-based practice centers go out and do this work. We post it. We post a draft research plan. We get comments on it, and we finalize the plan. The evidence report is produced, a systematic review. We draft evidence report. We post that for comments. Then we finalize it. We then develop a recommendation based on those evidence reports. We post a draft recommendation, we get comments, and then we finalize the recommendation. Now they come out in JAMA by and large currently. We get a lot of feedback, believe you me. Our draft recommendation for cervical cancer screening probably got 3,000 comments. So it's a very helpful process to us because we do get very valuable feedback. Here's our grades, and Matt showed you the new HAACC grades. This is what we use. No one else does, but anyway, it's in the Affordable Care Act. So we rate things A, B, C, D, and I. So A and B are both recommendations to do something. C is a recommendation to do it some of the time. D is a recommendation to usually not do it, and an I statement means we don't feel the evidence is strong enough for us to make this judgment about benefits and harms. So I won't go through all the details here, but that's the idea. In shorthand, A is really do it, B is do it, C is sometimes do it, D is usually don't do it, and I is there's not enough evidence. For coronary calcium, we came to an I statement. The grades matter because they summarize our views on the net benefit, which is benefits minus harms, and importantly, in this case, certainty. How confident can we be in the estimate that we've made of net benefit? So those are the two dimensions that determine what the grade is. If we have low certainty, we get to an I statement. We can't, without at least moderate certainty, we don't get to a grade. There are implications for coverage, but I do want to emphasize that we're making our recommendations based on the effectiveness. We are not making them in any way. Our recommendations do not, it's totally out of our scope. We're not recommending something's covered, not covered, etc. We're doing our best to make a judgment about benefit and certainty, and that's what grades are based on. And let me just say, please jump in with questions at any point. So let me show you the framework that we use for coronary calcium. And I'll go through it. So here's the patient population that we're talking about. So this is asymptomatic adults without coronary disease. That's very important. Completely asymptomatic, no known CVD, If they have known CVD, they have symptoms, whatever, this doesn't apply to them at all. So I would guess that many of the patients that Eveline and David and others see in their preventive cardiology clinics, I would assume probably aren't like this, but some are. So there's traditional risk assessment, and Matt talked about that. Our current recommendation in terms of risk assessment was the pooled cohort equation, which is the ACC one. It does overestimate risk, that's known, as Matt pointed out. And then the question that we ask is, does adding ABI or CRP or coronary calcium to the traditional risk assessment help? And look at if you look on the very right side of this, the outcomes that we're looking at or MI, cerebrovascular accidents, stroke, that is, and mortality. And so we were looking for evidence of changes in those events. We weren't looking for evidence that people adhere better, for example, which may well be true. So this top arrow with the number 1 on it is what we call direct evidence. And so that would be essentially a randomized trial of using coronary calcium versus not, and then seeing if you see an impact on MI, stroke, or mortality. Okay? We look for that. We usually do not find it for most preventive interventions. Lung cancer screening is an example where we did have it from the National Lung Screening Trial. So usually that kind of evidence isn't available. So we also look at what we call this indirect pathway. And here the question is, does the use of coronary calcium increase your sort of the test performance, your ability to risk stratify people? We looked at calibration, discrimination, and risk classification. And then we looked for evidence that based on these changes, you can do better. Here we're looking for trial evidence that showed a decrease in MI, cerebrovascular accident, or mortality. So you can see that it's a fairly high bar that we were looking for when we went about this. So,
Can I just ask a question?
you bet.
Is that the same for mammograms?
Each preventive service has its own analytic framework that is somewhat different. But we are always looking for changes in health outcomes. So we're looking for changes in mortality, quality of life, et cetera, no matter the preventive intervention. So prostate cancer screening, cervical cancer screening, all of those. So the general idea is the same across those, but each one is a little bit different, has its own analytic framework. Does that help? So now each of these numbered things is a key question that we go and then look for the evidence-based practice centers do a systematic review to look at those. And so I'm just going to show you the key questions. One, number 1 was compared to the pooled cohort equation or Framingham, does use of coronary calcium and these others, followed by treatment specific to risk level, lead to reduced incidence of cardiovascular events, that is MI, or CVA, or mortality. So again, part of the issue here in terms of how we might come to an insufficient, whereas others might come to a different one, is we're looking for those health outcomes as opposed to some of the other outcomes that Matt talked about. Number question 2 is, does the use of non-traditional risk factors improve sort of discrimination, risk reclassification? Number 3 is, what are the harms? And then 4 is, if you have this in people who you have done, say coronary calcium, can that lead to can that lead to changes in MIs or CVA or mortality? And then what are the harms? So this is just an overview of the evidence that we looked at for all things, not just CAC, about 23,000 citations that the evidence-based practice centers looked at. And I'll show you kind of an overview of the evidence related to CAC. That's down here. I know you can't read this, but this was just to remind me. These are the key questions on the top that I just showed you from that analytic framework. Key question 1, we found one randomized trial that looked at just randomizing people with coronary calcium or not. For these calibration, discrimination, reclassification, there are a number of articles. For key question 3, that's harms, there were 2 RCTs. And key question 4, one RCT looked at randomizing people to statins or not when they had coronary calcium, elevated coronary calcium. So key question 1, is this direct evidence? Do you have something where you randomize somebody to get coronary calcium or not and show that it changes their CVD mortality. There was the Eisner trial that Matt talked about. In those outcomes, it didn't show a difference. The trial wasn't well-powered to show those differences, so we couldn't conclude yea or nay based on direct evidence. Okay? In terms of the coronary artery calcium, in terms of discrimination, so discrimination is a measure where I'm looking at an individual person and try to predict whether they have an event or not. There were changes, and so this is measured by a C statistic or the area of the ROC curve. There were changes that varied from really pretty small to larger. That probably is MESA. I think you guys were at the top end of that. But these smallest, so some of the smaller, we looked at all the evidence, and in general, the clinical significance of these very small changes in the discrimination is hard to know what they mean. Yeah.
You're using the entire population.
We're,
You didn't ask the question about intermediate risk.
That's absolutely right. Another very important difference.
I just think that if you look at those areas of the curve improvements for the population that is diagnosed in the guidelines, the changes are in the order of 0.3 and 0.4. Massive changes that have never been seen before in the world of prevention. And I promise you, in the world, you cannot find another example where you can reclassify people better for any outcome than a calcium score. But the question has to be, not in the world, not screening everyone from infants to people who are 90, but screening the intermediate risk people who you might want to apply this test to. And that data is available and was not referenced too much. I was a content reviewer for U.S. Preventive Task Forces, and I tried pointing this out. But those numbers that you say are small are quite large in every trial ever published. If you look at the intermediate risk population where calcium score may be of use.
I think that's an important.
I'm just saying, that's just, so I just want people to recognize that if you ask the exact same question, does calcium scoring improve risk classification in intermediate risk patients, you would answer that it has a dramatic and large increase. The same reviewers would come to a totally different conclusion. So it's the question that's being asked, partly, I think, that differentiates what 27 organizations have concluded and what your organization concluded. I don't think it's the end point. I think it's the population that you assess. You assess the world.
We did.
We only assessed intermediate risk.
Yeah,
So
no, I think that's a very fair point. Yeah, fair point, and I would agree, changes of 0.2, 0.3, something like that, an ROC curve are quite significant.
Yeah, I mean, there were big changes.
Yeah.
It wasn't just MESA. I can show you many studies.
But our question wasn't,
I realize that. I know.
yeah, and
So it's the
Matt,
question you asked that might change the
yeah,
result.
and as Matt's pointing out, our question was not what about intermediate risk, our question was about what do you add to risk stratification for everybody, and that's where we came out. So I'd be interested in Matt's comments and others too about this. So you do get, of course, reclassification, but this is from MESA, and I just wanted to point this out, and you'll give me some comments, I'm sure. So if you look at this, what we're going to look at, so Matt talked about this, the risk classification, reclassification literature is fairly complex, I would say. I don't know if you agree. And because they all use different thresholds, or they might be reclassifying you from 3% to 5%, or 12% to 14%, and they all use different ones. But look at two different groups here. This is people who've had a CVD or CHD event, and then over the other side is people without. And so in people who've had an event, you'd want the coronary calcium to increase your risk score, right? These are people who have had an event. People who have not, you would hope that whatever kind of non-traditional risk factor you use, it would reduce your risk. What you see, of course, is that that does happen some of the time, but both things happen. You have some people that move up and some people that move down, and so the absolute number of people reclassified, let's look just at this bottom row, this is coronary calcium, so 76 people appropriately reclassified up, but 19 reclassified downward. If you look at per 100 people who are reclassified, you see that about 4 times as many people are being reclassified in the right direction as in the inappropriate direction in people who've had an event. In people without an event, it's not quite as good a story there. 202 people appropriately reclassified downward, but about 500 reclassified upward. So And again, I don't know what it would look like just in the intermediate risk people, but that would be very important.
So I showed you the exact same author, Yaboa, who wrote this paper, and I showed you the intermediate risk, where it reclassified, the net reclassification index was 66%. It reclassified properly 2/3 of people in intermediate risk. Because then it's easier to move them up with a small increase in calcium, and a lot of them have 0, and it appropriately moves them down. This is the entire MESA cohort. And again, it's the question you asked. So Yaboa, the same author, published 2 papers. One, dramatic improvement in net reclassification in intermediate risk, and small reclassification, net reclassification in the overall population. So you chose the small population, I chose the large, but it's the same author doing the same math.
Yep.
Totally different answers, so it's interesting.
Yeah, so I mean, I
The
think,
question you asked, I think that's so critical.
well, and I think it also points to the importance of who you're using it, and if it's the intermediate risk people where you're seeing this to help you as much. Question?
Those ones appropriately reclassified downward, did any of those have, they had events, did any of those have a calcium score of 0?
That, I don't know. I don't think that was presented in
It's
here.
very low. In Mesa, in 10 years, the event rate was 0.1% for 0. So
I'm
there
sorry,
might have
say-
been, there might, 0.1%. So 1 out of 1,000 people who had a score of 0 had an event in Mesa. So of those 202, probably 2 or 5, but it's not a lot. 0 is still pretty, in Mesa it was excellent.
But I mean, this group here is people who were known not to have an event.
I was talking about the other group. The
Yeah.
ones that had
Oh,
it.
yeah, okay.
There were a couple, but it's a small number.
Yep. I think a very interesting question also is the number of people who are 0, and you said it's high in
Mesa
most.
is about 50%.
Yeah.
And that's a population-based sample.
Yeah. All right, so harms, Matt also talked about this a little bit. What are the harms associated with risk assessment? Not a whole lot of evidence for coronary calcium. 1 RCT, 1 cohort study using administrative data didn't find any increase in cardiac imaging or revascularization. 1 study from Medicare did find increased cardiac imaging and revascularization in asymptomatic people. You don't know a priori is that good or bad, right? I mean, some people might have appropriately been revascularized. But if a lot of people are being revascularized who are completely asymptomatic, it provides you a signal that you might be worried.
And wasn't that portion, didn't it say those that, in the Medicare data, that those that did get the treatment lived longer?
That is not something that we saw in this, but so I don't know the answer to that. But this was just looking at sort of changes in the utilization of procedures.
But just one thing, and I totally agree with that, but there was a nice randomized trial done in the military called the PAC study, and they looked at harms, and they found that there was no increased anxiety of having a positive score, which was something that you'll hear bandied about by antagonists of calcium scoring, even though it's never been shown in any study ever. But there is a prospective randomized trial. The endpoint was, were they more anxious if they were found to have calcium, and they did not find an increased level of anxiety.
Our review showed the same.
Yeah, so I'm just
Yeah.
saying it's another potential harm of calcium scoring.
I didn't present that because it
Yeah,
didn't show
I
it.
just
but
think it's
that's-
something that people think about a lot, and somebody up in Northern California likes to talk about that, even though there's no evidence.
Yes, question back here.
I do think there are some,
Oh, no.
I do think there are some studies, and they might also be VA, that show an increased risk of finding incidentallomas, as they're called, in CAC scanning, and having additional testing related to that to work those other findings out. So I don't know if you categorize that as harm, but certainly additional costs, additional testing.
And we look at that, and that's a fair point, and Matt, I'm sure, could probably talk more about this. We worry about that with everything. The problem is, so like lung cancer screening is the poster child for
Right,
incidental
exactly.
findings, because we find stuff, much of the time. You don't know for sure whether that's good or bad. We kind of think it's often bad, because these are probably things that, but we don't know. But we note them, and just so people can talk about it. So now then, to this question, if I'd already got the coronary calcium, in addition to these traditional risk factors, does that lead, can I then change treatment to lead to reduced CVD mortality or both? Again, we're looking at the whole population. So in one fair quality trial, asymptomatic people, high calcium scores, LDLs, less than 105, didn't find a difference in CVD outcomes with torvastatin versus placebo. Again, it was underpowered, so we concluded not definitive one way or another. So let me go back to this analytic framework, and I think now that we've kind of gone through the evidence, where we come to, you know, our eye, where other people, and certainly AHA, has just has done something differently. If you look at this direct pathway, which is what we hope to see, we hope to find some direct evidence. We only had one RCT, which didn't show anything. It was underpowered, but so we can't conclude that there is an effect there. Then there's some improvements, as Matt talked about in detail, with calibration, discrimination, and risk reclassification, and as he pointed out, maybe the most in the people where you care about it. But when we look at this linkage, which we need to see in order to make a recommendation, one RCT that didn't show anything, it was also underpowered. So in terms of this analytic framework, we were not able to fill in all the links here to come to a recommendation. So where did that leave us? It leaves us with this I recommendation, and David pointed this out when we first started. It's neither a recommendation for or against. It means in our framework we didn't find the evidence to say no or yes, and we would certainly welcome, and we say this, of course, that this is a key research gap, and Matt and others here have been kind of moving the field forward to help close that gap. So that's where we ended, and I'll stop there. And
I have one question. So do you think that if this were reviewed again, using the data that Matt presented, could it someday move towards the recommended in some cases, like the intermediate group, or is that not going to be evaluated?
So I'd say a couple of things. We have eyes on a lot of things, and I've said that's primary care customers hate them the most, and they're frustrating for us. And we see some of these eyes, we think it's never going to change, right? This, I think, is something where the evidence is accumulating. There was more evidence this time when we looked at it last time. I think it is feasible. Now, people may not decide to do it, but it would be feasible to do trials that show changes in outcomes. They would take a long time, or have to be large, but you could do it. I mean, there's not any reason it couldn't be done. Some of the eyes we feel like, you know, there's just not, it's not likely to ever actually get done. But this could be. In particular,
An extension of the question, and given the discussion here, we do suggest modification of the analytic framework itself. Because if I understand the preventive task force correctly, you really don't look at, maybe you do, but under more factors, it's subgroups. In other words, this technology, this intervention, look at the whole population, and it doesn't, you know, the weight of the evidence, but maybe in subgroups, age, gender, whatever it might be. In this case, the intermediate, etc., there is evidence.
We do look at subgroups, actually, and this would be a key one for us to look at the next time.
Okay.
We spend a lot of time looking for evidence in subgroups. This would be a case, in most cases, we don't find anything, you know, ethnicity.
So you would come out and say, based on the accumulated evidence, there would be a recommendation that in this subgroup, there's evidence that this should be done.
Well, I would prejudge the deliberation.
Write that down,
I will take this. I'll be off the task force before that happens, and safely in an undisclosed location.
So I am fascinated. You know, I'm not a data person, but I'm fascinated how, and Matt, you've done an amazing job for 20 years, how mammograms and colonoscopies became a standard at 40 and 50 years old, and we can barely even get the intermediate. Like what was their findings that, because as a woman, you can't look at one woman in this room and determine who's going to have breast cancer. But every single one of us got a mammogram starting at the age of 40.
So I can speak to both of those. They're for mammography and for colorectal. So for mammography, they're randomized trials that show reductions in mortality. That's what we're looking for when we are looking to make a recommendation. So they're very old trials, And there's been all this argument about what do you do in 40 to 50s, but for older women, there are randomized trials that do show a reduction in mortality. Colorectal cancer screening is this, breast cancer mortality. Colorectal cancer screening is the same. They're randomized trials that show reductions in colorectal cancer deaths from screening. So that's the kind of study that allows us to make a recommendation with confidence. Colorectal cancer is kind of the poster child because it is a very large benefit relative to most other screening, mammography, or prostate cancer is sort of the very low end, colorectal cancer is sort of the high end. So there were studies that showed if you randomize people to screening or not, you reduce the number of deaths from either colorectal cancer or breast cancer.
And what was the number of deaths and whether it be breast cancer or colon cancer prior to doing early screening, early prevention?
Well, they were higher. So
Was
for
it as high as heart disease and heart attack?
Oh, well, no. I mean, heart disease is you know, as Matt presented the evidence, that's right. Those studies could be done, right? I mean, and they would be very helpful to us. We would love to see studies like that. And so I can't answer, I mean, the other people here would know much more about the cardiovascular
I
community.
think Dr. Alco was trying to get in,
Yep.
we can hear from her next, please.
Yeah, so my question is, even if you were to redo your task force assessment, looking at that intermediate subgroup, there are no outcomes, RCT data.
Right.
And so you wouldn't change your recommendation based on the RCT data. I mean, what the AHA used was observational data.
Right.
To make these recommendations, and it sounds like your gold standard will not be met until then. RCT is definitively done.
It's complicated, as they say.
I don't think that's correct. You don't need an RCT to get a grade by US Preventive Task Force. You can't say most of the time and then say you're not going to do it this time. That's not a fair thing. It's not a standard that we need a randomized clinical trial that improves outcomes to get a grade of an A or B at US Preventive Task Force.
That's correct.
Right, so.
No, that's correct. I would just say that,
The playing field has to stay level, and we've been climbing uphill with coronary calcium, because every time we achieve something, we go, well, now the grade is higher. I mean, CT angiography is a good example where it's the most accurate diagnostic test at the lowest cost available, yet some insurance companies don't want to pay for it because it doesn't improve outcomes. But nuclear doesn't improve outcomes, and CAP doesn't improve outcomes, and stress echo doesn't improve outcomes. Well, the playing field has changed since those tests were approved. And it's just not fair to change the playing field.
I would say the playing field is.
And I think the playing field is level, and I don't think
Yeah,
you
it
need a
is.
randomized clinical trial to get a US Preventive Task Force with an A or B.
Well, let me give you an example. HIV screening area that I've worked in for years, there are no randomized clinical trials. So we can get there with the proper links across there without a randomized trial. But what would have to happen, again, not prejudging the next iteration, we would either have to change the outcomes we were looking at, or there'd have to be observational studies that looked at those outcomes.
Can I say
Dr.
something?
Joe Sky from the Air Force, and Jim Adams,
Let me just say, I interrupted Joe here,
can you speak up?
but the mammography isn't a risk factor for disease, it is disease. Colorectal cancer, you screen for colorectal cancer, you have colorectal cancer. You don't look at a risk factor for colorectal cancer. Mammography is not a risk factor for breast cancer, it is breast cancer. So you're looking for direct, so that timeline between a diagnostic study and a diagnosis and a treatment is very short in those studies, and it's a high recommend. That's why those studies showed it. You're looking at a study that predicts it, a risk for disease. It's a marker for the disease, but the best predictor of the disease is an early manifestation of that disease, which you're getting, and you'd like to get it before it becomes clinically manifested by stroke or heart attack or yeah.
I'm glad I let you go first.
If each person could say their name and where they're from, that would be great. And
So
Back from Afghanistan.
I'm Joe Sky, and I just deployed to Afghanistan for 6 months to the ICU there.
Are you doing calcium scales?
Yeah, indirectly. And then I'm chief of cardiology at Travis Air Force Base. But prior to becoming a cardiologist, I worked at the Air Force's Center for Cardiovascular Screening of our pilots. And I was the chief of the internal medicine branch there, where there were 2 cardiologists on staff, and we have the reputation, we have the history of having used coronary calcium the longest of any institution. We started in 1982. And I think the important thing that's been pointed out here is what question are we setting out to answer, right? And I said I'm glad I let Jim go first, because our description of the use of coronary calcium is it is direct radiographic evidence of coronary artery disease. We don't see it as a risk factor. We see it as a radiographic marker of disease when